think we have a question in the center, if you can pass the microphone down.
Thank you very much. That was an excellent panel of talks, and I have to say I owe it to Dr. Singhal for allowing me to come here and shadow him and watch him in the operating room and doing lympha. And since the time that I've came, I actually have done about 16 lymphas on patients who are getting AL&D. I work at Henry Ford Hospital in Detroit. I work with Lisa Newman and the new group of 5 breast surgeons, so we have a very heavy volume. But like you've described, there has been a significant decrease in the rates of AL&Ds. And I essentially offer AL&Ds, or the lympha procedure, to all patients getting AL&D. I don't have an exclusion criteria, and so I would like to understand a little bit more about why we should have an exclusion criteria, because I feel that any patient having an AL&D should have the opportunity to have lympha. Really, it only takes me about 45 minutes to an hour to do, one bypass. If I'm doing 2 or 3, it might take me a little bit longer, but the risks are minimal. So that's question number 1. And then question number 2 is, Drew, if you would just go over one more time your for the Fluorescein mixture that you use, and the exact time that we should be injecting it.
Great.
Thank you.
Tanya, it was great having you in Boston as well, and your entire team that came a few months ago. In terms of exclusion criteria, I don't have any. I counsel my patients, as I told you, and no patient has ever said no to me. And I have enough patients coming into the lymphatic surgery clinic who have chronic lymphedema with a BMI less than 30 that I offer it to everyone. The mixture is the stock solution of Fluorescein, which is 10%. You take 2 cc's of it, you add 7.5 cc's of normal saline, and then a half cc of albumin. And yeah, it's 5% albumin, and that's really important because that keeps it in the lymphatic system.
Thank you.
I completely agree with you about exclusion criteria, because there should not be any exclusion criteria by now. But the problem are breast surgeons. They have to change your mentality, because there are some breast surgeons that still say that they have no lymphedema, because maybe they don't follow the patient, so they don't understand why you propose lympha. So you are completely I completely agree with you, but most of them ask us, can you try to select high-risk patients? So maybe we can do lympha only for them. So it's a question of mentality, I think.
So I just, but you have some criteria that you're using in Italy in terms of transport index and BMI. So are those gone now? For selection?
Not yet.
I'm just trying to understand this.
Not yet.
Oh, okay.
I hope in the future.
Okay, okay.
They obliged me to do something.
But your inclination, it sounds like, is to,
yes.
is to do away with those.
Yeah. Even because, as our colleague told us, axillary nodal dissection are even less and less now. So it is not. There's no sense not to do lympha.
So I would like to just add one comment. So, we're talking about axillary dissection like it's one thing. And having been part of the B32 trial and going to multiple sites to validate sentinel node technique and observing surgeons at different centers, very good centers, small centers, large centers, the way axillary dissection done, it is not a standardized operation today in this country and probably around the world. And there can be axillary sampling, there can be radical, there can be level 3, there can be preserving the lateral nodes. So my only thought about all that is that there is kind of another way forward which may be more practical. So most centers will not have the expertise to offer lympha to patients who are going to get dissected. It's just the reality of it, because it is a high-tech procedure. So there needs to be, I think, a middle ground, and that's where I think axillary reverse mapping really will have a sweet spot, because I think there are patients who get dissected, but where many of us will feel that it's safe to preserve some of the axillary nodes which map from the arm. And many of those patients are going to get radiotherapy as well, because the perfect storm, as you know, is getting fully dissected and then getting axillary radiotherapy. That's the bad scenario. So there is going to be a middle ground where patients may not need to have lympha and maybe can have axillary reverse mapping, and you can still reduce the morbidity from the procedure. So.
You have a question, Alex?
Yeah, question for Drew and Dr. James. I really appreciate the fact that you guys have embraced this quite a bit. My question is more of the workflow that you brought up. As far as staging the axilla on the high-risk patients, how did you guys decide as far as doing that versus maybe just staging the axilla first and coming back later and addressing the breast?
So I want to make sure I understand your question. So you're asking about how do we decide when to do a combined procedure versus doing a sentinel node biopsy and coming back again another time?
Correct. If some certain centers, it would affect the breast reconstruction if we just stage the axilla first before getting the sentinel biopsy and coming back and doing a mastectomy later.
Okay. So and when you say affect the reconstruction, you're talking things like radiation.
As opposed to plan for breast radiation.
So yeah, it's a great set of questions. So let me answer them in reverse order. In terms of the radiation therapy, at least in our center, our radiation therapists, oncologists rather, really believe that the decision for radiation therapy, PMRT, is based on the initial node status. So even if a patient has a great clinical response to chemotherapy and becomes node negative, they'll often still treat them with the radiation therapy. So staging the patient before or after won't make a difference if they present clinically with disease. In terms of the combined procedures, as I mentioned, if we know up front, let's say someone comes in with a grossly palpable disease or not going under chemotherapy, or they have inflammatory disease where you know you're going to do a node dissection anyway, then that's an obvious case for a combined procedure. Anything else should be done as a stage, because what I don't want to do is to get into the operating room, do a lymph node dissection, and then send the patient for lympha, because that can't be done that way. So basically, I stage all of those patients who I find out either at the time of surgery that they have positive disease.
Are you asking, though, Alex, about doing a sentinel up front before mastectomy? I think so, doing a sentinel prior to the planned mastectomy so that you'll have the info before you actually go in, and you'll know whether a lympha is going to be involved, where your your plastic surgeon will be there, and you can kind of, just from a workflow standpoint of getting that info up front instead of...
No, that's a good question as well, and I'm interested in hearing the answers from my colleagues as well. But generally speaking, that's not something we do in our practice because, again, we're going to base the decision based on their initial clinical presentation. All of our patients are also getting axillary ultrasound. So if we identify abnormalities, we'll do an FNA. So oftentimes we know the positive patients long before we get to the operating room anyway.
Got it. I have a question about insurance, actually, in these procedures, because I think that this is another thing in terms of widespread adoption of the technique. Are you able to, how are you getting insurance coverage, and if so, how? Because these new techniques are always a challenge because they're considered experimental, and insurance companies will balk.
Again, in Florida, we didn't have that many problems. We are here, so we're fighting them. We're 1 year into fighting them. Again, many rounds of denials.
That I've been using, which I was told when I went to the meeting, the ASRM meeting, was the 5206, which is the repair of vein and vessel, and we have not had problems with utilizing the 35206. It's not that much reimbursement, but it doesn't take that much time to do this operation.
So you get authorization for it?
We get prior auth.
Okay.
I think it's also important
Another question
to mention that although we're still having that negotiations about reimbursement, patients are not being charged for the procedure. Yeah. So the patients are getting the lympha at no charge, and we're trying to work it out with the insurance companies on the back end.
So yeah, I'm a physical therapist, and I practice in northern New Jersey. So when I have a patient who is a friend or I have a friend or whatever, but when someone asks me for a recommendation, they are newly diagnosed with breast cancer, what am I telling them? Am I sending them into the city? What would I be asking them? Or telling them?
Maybe they can ask about lympha if the surgeon does it. I mean, we've been using it. I'm a believer. I think it's just once you start using it, you're a believer. But I think just educated patients are.
Where do I send them?
Well, I think this is part of the problem. We're these symposiums are our means of spreading information, and I know Shelley and Drew and actually Francesco has been at many of the meetings demonstrating the technique and showing, you know, live surgical clips. He's done live surgery at the Barcelona lymphatic meeting. I think it's starting to take off. Shelley made it a priority at the ASBS to discuss it as part of the panel. There's a lot of effort to raise awareness, but it's a cultural shift, don't you think? I mean, as you said,
Absolutely.
I mean,
Send them to the Bronx.
Yeah. We have, for instance, one surgeon who a fantastic relationship with. She actually is director of her breast program out in Maine. And what she'll do is any patient who she suspects might require axial lymph node dissection, she actually sends down to Boston for evaluation. And we've actually worked out a system of collaboration where patients undergoing neoadjuvant chemotherapy will be followed by her, sent down for reassessment. Again, if at any point it looks like we need to do the node dissection, we're prepared to do the procedure with the lympha. So I think those type of regional, collaborative, collegial type of relationships are what's going to be important until lympha is more available in other centers.
But I think it's a great question because I think from the patient's perspective, you know, advocates perhaps should really endorse when patients go for their consultation about their breast cancer, and if they're going to need to have axillary surgery as part of that, it's a fair question to ask, doctor, what are you going to do to reduce my chance of developing lymphedema? And it's not just one thing. It's not just lympha. It is a very important modality, but I think more and more as patients become aware and ask those questions, you know, the patients lead usually. A lot of changes that have happened in breast cancer have been all driven by patients. Breast conservation, immediate reconstruction, you name it. So I think it's important for the patients to be educated and to ask the right question.
I have a question just to the panel because of there's a certain percentage of patients that don't get better with or still develop lymphedema and potentially from radiation. Most of these patients are going to get radiated. What about doing this outside of the axilla, a little more into the arm in terms of, I know you do it in cases of where there's established lymphedema. Is that basically sort of your fallback if a patient fails to go back and do something a little more distally in the arm?
I think it's a technical problem. Sometimes you can find only one lymphatics. Some other cases you can find 4 or 5 lymphatics. So, and the vein. And then the distance in between the two. So I think that when lympha doesn't work, it is a technical problem. It's not radiation. I'm not scared about radiotherapy because apart from the fact that mainly you radiate the mammary gland and not the axilla, but in those cases in which you irradiate also the axilla, the anastomosis is in the upper external part of the, and so, and then radiation is harmful on the tissue, not on the lymphatics. There was a paper from a French colleague who studied radiation on the vessels, and he demonstrated experimentally that you have no damage on the lymphatics, but on the surrounding tissues. So maybe I'm not so scared about radiotherapy.
I think one of the things that's key, Mark, and Drew and I were talking about it, I think until we have imaging which demonstrates, you know, not lymphscintigram because you really can't see it well enough, I mean, it's functional, but that demonstrates patency of the lymphatic venous anastomosis with lympha, that picture will be worth 1,000 words. Because I think all the skeptics out there are saying, yeah, well, you know, the clots doesn't matter, you don't know, and we don't really image it. We have indirect ways, but some direct imaging of that, I think, will transform the field.
Joe?
Just a quick comment, a comment I think to follow up with what Dr. Feldman said. The first case of lympha that I did was basically because a patient asked their breast surgeon, they want to go to a place that actually does lympha. So when the market of patients, I think the thing that will change practices is when the market changes, just like sentinel lymph node biopsy, when that was being offered at only a few centers and it was still maybe experimental or investigational, patients started asking about it, and those that did not lost patients. And I think that's just the general nature of humanity and markets and things like, but I think ultimately the patients knocking on the door of the surgeons, asking them, what are you going to do for me? Like Dr. Feldman said with regard to lymphedema will help not only lympha, but the whole lymphedema community.
Well, thank you, everyone. I think we have to move on. We're a little over. Thanks very much.